The views and opinions expressed on the Healthcare Advocate Show do not necessarily represent the views and opinions of Connoisseur Media or its advertisers.
Revolution Healthcare Radio is brought to you by Home Helpers of Connecticut, in-home senior care services, and Protein Sciences, the creators of Flu Block, a safer, more effective flu shot.
It's Revolution Healthcare, the show that keeps you in the know about the ever-changing healthcare system. We all need answers to our many questions about health and the revolution in healthcare. Presented by Patient Advocate for You, making sure that your healthcare is coordinated properly. And now, here is Sharon Gauthier, taking your calls and sharing information. 1-888-574-2723. 1-888-574-2723.
Good morning, everyone. This is Sharon Gauthier. Thank you for joining us today. I can't believe the weather. We haven't even gotten our Christmas tree yet because I don't think we feel like it's Christmas, but we are going out to get that today. You're listening to Revolution Healthcare Radio. This is, again, Sharon Gauthier. I'm a registered nurse, and I have a private care management and crisis intervention service. I'm very happy today to have Dr. Luis Roberto Gonzalez, and it seems as though those Hispanic names have that flair to them, Dr. Gonzalez. Like when I say Sharon Gauthier, it doesn't sound the same as Luis Roberto Gonzalez. He's from St. Francis, and he is actually the chairman of the psychiatric department. I have a great love for St. Francis. I went to St. Francis School of Nursing, worked in their ER for a number of years. Still have some great friends over there. Patty LaMonica, Dina, and I from the psychiatric department have had some pretty lively discussions about dementia. And Chris Dadius, I never know how to pronounce his name, and I have also had some great discussions, and he's a wonderful leader for St. Francis Hospital, who's now partnered up with Trinity Healthcare. So today, the reason why I brought Dr. Gonzalez here is that we all know that mental health has been in the forefront of the news, and unfortunately related to a lot of gun violence and violence in general. And we also have a season that we're going into, which whenever we go into it, I do know that we have the longest day coming, which is pretty depressing that we already wake up to the dark and go to bed in the dark. He is going to talk to us about affective disorders and seasonal affective disorders. So welcome, Dr. Gonzalez.
Glad to be here.
So can you just tell us a little bit about your background? How did you even get involved with psychiatry?
I was finishing medical school around 1976, and that was the time of the big revolution in psychiatry. That was the time that there were converging forces between psychoanalytic movement in psychiatry and biological movement in psychiatry. So I saw there a big opportunity to enter an emerging and changing field. So that was the things that attracted me to psychiatry most.
I also read about you that as a board-certified psychiatrist and a leader, that as a physician, this was a quote from you, as a physician, I strive to provide excellent, compassionate care, working with my patients to achieve the best care for a lifetime. And I truly loved that quote, because how we feel, how we behave is a lifetime challenge. You know, we are going to go into periods of time of being sad and those feelings that we have that are sometimes appropriate. And sometimes I get a little concerned that those appropriate feelings end up in front of a psychiatrist who says, well, you're really sad, so let's give you a pill. So when we talk a little bit today, maybe you can comment on that, but particularly since we're going into the season and your expertise being the seasonal affective disorder, can you talk about what an affective disorder is? Because there are lots of terms used out there, not just the seasonal, but bipolar affective disorder, schizophrenic affective disorder. So we have many of our own clients who do have some psychiatric component. And is there a difference between someone who is a schizophrenic, has been diagnosed with schizophrenia, versus schizophrenic affective disorder? So if you can explain what affective disorder is.
Well, affective disorder is a state of mood, a state of either happiness or unhappiness. We go through periods of feeling good, feeling high, feeling happy, and we have periods of being sad, being low. Those are normal. People go through normal cycles. Where it becomes a disease or it becomes a disorder, I usually use the principle of frequency, intensity, disability, or prognosis.
Right.
So it is normal for someone to experience happiness or extreme happiness if something good happens to one person. For example, I win the lottery, I feel great, I get good news, I feel great, and that usually lasts a day or two, a week, and eventually you go back to your normal state of mind.
Correct.
Something bad happens, I have an accident, I have a family member that dies, I find out I owe a lot of money to the IRS, I get a letter, I become really very unhappy and very sad. It lasts for a week or two. Then I start thinking of ways of resolving the issue and then everything back to normal. It's sort of like a cycle.
Correct.
Life is a cycle to some extent. We have periods of being up, we have periods of being down. The key element is how big those waves are and how disabling they can become for a person. And that's where you start talking about a disorder, an illness, or a disability. Not everybody that's sad needs to be treated with medications. Nobody that's super happy or bipolar or manic or a little elated need to be put in medications or put in the hospital. And again, I do, how we call it the FIT principle, frequency, intensity, disability, or frequency, intensity, and prognosis. So when you start talking to a patient, you look at those items, how frequent this problem is, how intense it is, does it interfere with your daily life, to then make a decision, to start looking at a decision tree as to what you're going to do for this person. Sometimes just talking to somebody helps. Our society has changed a lot. We used to be a very close-knit society. People used to belong to churches. People used to have a lot of supports. When people will get sad, will get unhappy, there will be a lot of support, family members,
correct,
church members.
Families all live together.
Yeah, and now that's gone. And people have to rely more on professionals or other sources to get that kind of help.
So intensity and probably length of time, correct?
Yeah, that's correct.
And disabling. So disabling in the sense that if someone is in this happiness mode, which can be called manic, and you are there for a number of weeks and you can't sleep and you can't go to work and you can't function, can't take a shower, can't do whatever, that's where the disability comes in, and that's when a diagnosis might be more appropriate.
That's correct. Or people in those kind of states will go out and spend all their money and buying all kinds of stuff for different people or for themselves, money they don't have.
So if anyone's interested, please call our number at 888-574-2723. That's 888-574-2723. So let's talk a little bit about how the weather and this seasonal affective disorder, how long has that been around? Because I don't remember this when I was, 20 years old, which was a long time ago, as being a condition. What is that exactly?
Well, it's sort of like during the winter months, especially in the northern latitudes, there's a decrease in the amount of sunlight available. People develop, this lethargy or this sadness. Some people, for example, the prevalent studies are that around 10% of individuals in the northern latitudes, like, Virginia,
Alaska.
Alaska.
What does Alaska do?
Yeah.
Don't they have days of just darkness?
That's right. And what they do is they develop more of a typical type of depression. Most of the typical depressions involve, insomnia, hyperactivity sometimes. The kind of depression that you get during seasonal affective disorders is the one where people eat more, there's lethargy, they sleep more, they feel sad, they feel blue. Now, that's true for most populations except one population, Iceland. Iceland is the only country where they have made studies for seasonal affective disorders, and they found that there's no increase in its prevalence or incidence, and they think may have something to do with genetics, may have something to do with the way the society is. But that's the only society that you have seen that there's no increase in seasonal affective disorders.
So if you, and I've spoken to people who feel that they have this, because normally when it's sunny and nice outside, they don't feel that way. What is the treatment for that? Is it buying a sun lamp in your bedroom?
Sun lamps can help, especially a sun lamp that will give you, if you look at the brochure that have 10,000 lumens, that seems to be the standard for that. You can do more simple things like being outside for an hour and a half in the morning so you can get direct sunlight. You can do other things like exercise, look at your nutrition. Sometimes vitamin D may help. If none of that helps, then you can talk to a psychiatrist, and there have been some studies in which they have used medications like Zoloft for the treatment of those seasonal affective disorders. But again, it goes back to frequency, intensity, and disability.
And would that medication be temporary?
In some cases, it's temporary. In some cases, people may need it more often. Some persons with major affective disorders had a variant in which they become more depressed during the winter months, and those patients may need medication during the whole year.
So you're listening to Revolution Healthcare Radio. We're speaking to Dr. Luis Roberto Gonzalez. He is a leader at St. Francis in psychiatry. Our number is 888-574-2723. When we come back, we'll continue our discussion on affective seasonal disorder.
Uh-oh, flu season again. Time to get a flu shot. You now have a choice in flu vaccines. You can ask for Flu Block.
It is the healthy individuals that carry and spread the flu. Every year, about 30,000 Americans will die as a result of the complications of influenza.
That's one of the reasons why I had an interest in it, is that our population, that our service tends to manage, our elderly. People were having to get a booster with the flu vaccine. What I liked about Flu Block is that the people last year in our group, the clients of ours that got the Flu Block vaccine, did not get a booster, and they did not get the flu. And the people that didn't get the Flu Block vaccine either got the flu in addition to getting the vaccine, or were told by their physicians that now we had to try to create a process for them to get a second vaccine.
The next time you get a flu shot, ask for Flu Block, the pure choice, because you have a choice in flu vaccines.
Home Helpers is a franchise in Connecticut, and what I was impressed with Home Helpers is their passion for what they're doing. We worked with them in the past, and we recommend them to our clients.
Are you looking for senior care for an aging parent or loved one? Are you a new mom or working parent who could use an extra hand? Let Home Helpers of Connecticut make your life easy. Get a free consultation. Call 860-698-2244 or find the nearest office at homehelpershomecare.com.
Welcome back, everybody. You're listening to Revolution Healthcare Radio. Your host is Sharon Gauthier. I'm a registered nurse, and I have a private care management and crisis intervention practice, and we are speaking to Dr. Luis Gonzalez, who is the chairman of the psychiatry department at St. Francis Hospital. Our number here is 888-574-2723. I would probably think that everybody's out today in the weather and not listening to the radio, but do know that you can go on to our website, which is Revolution Healthcare Radio, and pick up today's show. And I believe it would also be available on St. Francis's website, too.
That's correct.
Correct, because that's where I picked up your previous shows. So right now we were talking about SAD, seasonal affective disorder, and the treatment of it. And Dr. Gonzalez, before our break, was talking about it can either be holistic approach, where you go outside in the morning when the weather is better and you've obtained some sun, have a sun lamp that you get, and exercise. Everybody, knows exercise is better. I go to the mall because if I walk around the mall that's nice and bright and everything, and I get my exercise, that also helps, but I don't think I have the disorder per se. So I wanted to talk a little bit now about access. Dr. Gonzalez, before the show started, we did talk about how the emergency department, having come from that being my background, tends to be the place that when people are in crisis end up. And my worry about that is that the unit that people who are suicidal go into is the same unit of the guy that they found on the street who's intoxicated and belligerent and ends up in that unit in 4-point restraint, or the gentleman who might have overdosed on a medication will initially go. And I have seen a change at St. Francis in particular, because now I see more in the back, which is the green pod, I believe, that they tend to bring people in with those issues first and they're medically cleared, which is a bit of a change from when I was practicing there as a nurse, in that they would initially come right into this pod and then they would continue to be medically clear. So I was kind of glad to see that. But ultimately, when they're medically cleared, they do end up in this unit. And it's worrisome to me because, someone who is suicidal, that's next to the guy that's in 4-point restraint because he's such a behavior problem due to drug use or alcoholism or pacing the floors. And then my dementia patients, which Dina and I have gotten to a lot of discussions about, in that if they become a behavior issue, usually related to a urinary tract infection, that's where they'll end up in this locked unit. And again, I have an 85-year-old next to the 25-year-old who's swearing and cursing about, where am I going to go and who's going to help me. So if we can talk a little bit about access and what your sense is about that and what options people have if they're suicidal or feel there's an issue, and your feeling about the ER.
Well, access, a lot of it is driven by economics to some extent. What kind of access you can get as an emergency depends on where you're located. It depends what kind of insurance you have, what kind of connections do you have. The emergency room should be the last option for anybody, because when you go there, you may get the help that you are looking for, or you may get the help that you are not looking for. On many occasions, somebody may come into the emergency room complaining of being sad, being suicidal, and end up being committed to a psychiatric unit.
Right. Because
there was not enough time to develop a safety plan. There was not enough time to bring resources into the place that will do that. The emergency room is just a triage area.
Correct.
So you go there and you state, I'm suicidal, I feel sad. The crisis worker, anywhere, not saying about any particular emergency room, don't have the time to worry about you. So the safest place is to put you in a hospital. You end up in a hospital on a 15-day commitment, which is not the ideal thing.
Correct.
for patients. Other places you can use 211. That's a good resource. Sometimes they can connect you to crisis clinics. Most of the lead mental health agencies in the state, when you call their number, after hours, it will fall back to a crisis worker. Like places like Capital Regional Mental Health Center, CHR, Intercommunity. They all have, when you call their numbers, access numbers during the daytime, they may say, if you're a life-threatening emergency, call 911, but then you end up in the emergency room.
Right.
But also you may end up talking to a crisis worker. Some programs have mobile crisis teams. For example, Willard Clinic, I used to work for them many years ago on their mobile crisis team. And when somebody was in crisis, they will go out and actually go to the person's house and talk to the person and avoid an emergency room visit. That was many years ago. I don't know how much they do that, but there was a lot of funding at one point to prevent patients from going to the emergency rooms and avoid hospitalizations. That would be the ideal setting for patients.
And I'm not sure whether or not that model is available unless there's a true crisis. For instance, if I can remember being a community nurse in the city of Hartford. If I went in to see a client and they, and I heard from the building they locked themselves in, they were threatening to hurt someone else. That was usually when we could call the crisis mobile team that could come in, kind of talk them down. The police were normally involved with it, and they would end up going to the hospital. But on a regular basis, to just be able to find someone to talk to, I guess there are, suicide lines. People forget that the holidays tend to be a very sad time for a lot of people. And I know, having worked in the ER for years, there's an escalation of people that come in the holiday time because of family dynamics or deaths. I know my father passed away on New Year's Day. I found him. And, for me, New Year's Day, even though this was 30 plus years ago, it impacts me that I always have that remembrance of that day. Again, I think that there needs to be, especially in today's world where there seems to be so much violence going on, and they always seem to connect it to someone who has a psychiatric issue. And what is your feeling about that? Like the nature of what's going on in the news right now with violence and always connecting it to a psychiatric issue?
Well, objectively, the proportion of people who get involved in mass shootings or crimes, the proportion of them that have truly mental illness is very low. I mean, the people that have been diagnosed, most patients with mental illness, when they have access to guns, what they do is kill themselves.
And not other people.
And not other people. The majority of the deaths with guns in the United States are suicides, not actually, going out and killing a stranger. Mm-hmm. That seems to be the minority of cases. But we tend to sensationalize them.
Correct.
Because it makes news.
Right. Right, exactly. So, do you have any thoughts on what other countries do when with mental health issues? Is it that our country has that disconnect now with the family unit and we don't have those people to speak to and call up? And, last night we had girls' night out. It was great. There was like 16 of us. Mm-hmm. We all sat and we're all in very stressful jobs. It's just a fun night to do. So, I have access to people that I can call. Do you think that that's a big answer to it? Do other countries have the same issues? I mean, I'm sure, the USA is not the only country limited to psychiatric problems. And I know you come from Puerto Rico?
Puerto Rico, that's correct.
So do you have any sense on what other countries do in terms of access or mental health issues?
Well, in terms of access, the United States have a very good mental health system, better than many countries. Some of the countries that have socialized medicines, you may have better access. You don't have to worry about having money or insurance to pay for the services. But other countries, family and church play a very important role in providing that support.
So, but when you look in the city of Hartford, where there's a church on every corner, mm-hmm. And it only brought to mind because I worked in the city for so long. Mm-hmm. And Hartford's had a huge problem with violence, and again, it's sensationalized. It was around the time that everybody was running. It's just an ongoing issue in an inner city. I'm not sure it's any worse than it's been in the past, but it almost says that doesn't work.
Well, I think in the city of Hartford, drugs play a very important role in the kind of violence that we see here. There's a lot of family disruption in the inner cities. You see a lot of single family households. You see a lot of absentee fathers. You see that gangs are running in the city, and all that promotes violence.
So regardless of the churches who've been very involved in trying to prevent, it's still a problem, and probably in every city, not just the city of Hartford.
Well, the other thing is the people you look at in churches are usually middle-aged. You don't see that many youth, and those are the people that you have a lot of violence now, gun violence, young people involved in the drug trade, involved in gangs. You don't see that many young people in churches.
Anymore.
So we are speaking to Dr. Roberto Gonzalez. He is the chairman of the psychiatric department at St. Francis Hospital. If anyone has any questions and happens to not be out on a beautiful day like this, our number is 888-574-2723. That's 888-574-2723. So let's talk a little bit about what the general public should know. So for our family, we have a family member that does have a mental illness, and as a family unit, we're always very alert to what to look for. So when there are some changes going on, we tend to spend more time with that person, tend to be more aware of what's going on. That's not always the case. And so what should families be looking for as concerns, even with their children?
Sudden changes in behaviors.
Okay.
For example, for persons that get very depressed and commit suicide, they become more withdrawn. They talk less. They seem internally preoccupied. They don't communicate that much. They stop doing the things that they normally do. So when you look at that sudden change, that should be a red flag that something is not right. And that's the time to intervene, or at least ask the question. What's wrong? What's happening? What's bothering you? Is it school that's bothering you? Are you getting bullied in school for young people?
Mm-hmm.
Is it something to do in the job that's not working well, that's making you angry or despondent? So look for those changes, those wide fluctuations. Is the person more irritable, more angry, seem more distant, seem less connected?
Mm-hmm.
That's usually a sign that something is brewing and the time to act has come.
And it's just a simple ask the question and not be confrontational. And I think I found that out as a family member, instead of going in, and rattling off, oh my gosh, things seem so different. What's the problem? The moment I say what's the problem, they think there is a problem. But if it's just a simple, geez, how are you doing? Sometimes it opens that door for people to speak with you, and then get your physician involved. And with us, I know we got our family physician involved immediately. That was not her expertise, but that was a window for us to go to, or an opportunity for us to access, well, where do we go? And then was connected. And it's very difficult, I have to say, to see psychiatry. The waiting time is very long. And what I have found out through our nursing practice and personally is that you have a lot of APRNs or psychiatrists who just manage medications. And then you have psychiatrists or psychologists that actually do therapy. And so when we come back from our break, we'll talk a little bit about the difference between the two and how we can connect the two, because I really feel that if someone needs medication that's being managed, more than likely the psychotherapy, or whatever, that may be the wrong term, some kind of therapy needs to go along with it. So we will be back shortly. You're listening to Revolution Healthcare Radio. This is Sharon Gotha, your host. I'm a registered nurse and have a private care management crisis intervention company or practice. Our number here is 888-574-2723. We are speaking to the chairman, Dr. Gonzalez from St. Francis Hospital, Psychiatric Unit. And we'll be back shortly. Home Helpers is a franchise in Connecticut, and what I was impressed with Home Helpers is their passion for what they're doing. We work with them in the past, and we recommend them to our clients.
Are you looking for senior care for an aging parent or loved one? Are you a new mom or working parent who could use an extra hand? Let Home Helpers of Connecticut make your life easy. Get a free consultation. Call 860-698-2244 or find the nearest office at homehelpershomecare.com.
You now have a choice in flu vaccines. You can ask for Flu Block. No actual flu virus is used. You now have a choice in flu vaccines. You can ask for Flu Block. No actual flu virus is used to make Flu Block. Flu Block protects against the flu. No gluten, no latex, no eggs, no antibiotics, or no formaldehyde. Flu Block is proven to provide broad protection against multiple strains of the flu. The next time you get a flu shot, ask for Flu Block, the pure choice, because you have a choice in flu vaccines.
Welcome back, everyone. You're listening to Revolution Healthcare Radio. This is Sharon Gauthier, your host. I'm talking to Dr. Gonzalez today, who's the chairman of the psychiatric department at St. Francis Hospital. Our number is 888-574-2723. We were just talking about the differences between going to see someone who might be a psychiatric APRN or a psychiatrist who just manages medications, and someone who may do both. So can you explain a little bit of the dynamics of psychiatry in itself?
Well, the person that are authorized to prescribe medications, so psychiatric medications in the state, are either APRNs, which are advanced practice nurses, or physicians who have training in psychiatry. Any psychiatry or any APRN can prescribe any medication that they want to. People are not restricted. So you would like to find an APRN that has training in psychiatry and has a lot of experience. I cannot make a clear distinction sometimes. I work in the inpatient unit a lot of the time, so I am at the receiving ends of the bad outcomes.
Correct.
from both APRNs and psychiatrists. So I cannot say that APRNs or psychiatrists are better than others. I have known many APRNs who are excellent clinicians, a lot of experience. Same thing for psychiatrists. I have seen patients from psychiatrists that come into the inpatient unit who have been clearly mismanaged by the psychiatrist. So it's a matter of knowledge, experience, and knowing when you don't know. I think that's the key element.
Anywhere in healthcare, I would agree.
Mm-hmm.
Knowing what you don't know. I used to tell my nursing students that. Don't ever think you know everything.
Mm-hmm. And knowing that you don't know. Because if you don't know, then you keep compounding the mistakes and the errors.
So with medication management, what I have found with our family member is that the APRN was managing medications, but I didn't get a sense that this family member was actually getting therapy. And she actually does know what she doesn't know, because now that we had another crisis that had happened, she actually said, I think you need a psychiatrist who does therapy, medication management, has a better sense of what's going on with you. So are there psychiatrists in APRN who just do medication management and then ones who do both?
That's correct. And again, a lot depends on economics.
Mm-hmm.
Like some institutional settings, you may have psychiatrists who do both. In private practice, because of the economics and health insurance issues, some psychiatrists are being forced in only doing medication management.
And if someone's taking medication, it seemed to me that they probably could use some kind of, psychotherapy or whatever kind of therapy they have. I wanted to talk to you a little bit about DNA and those companies that provide DNA evaluations, I believe. So the company that I know we got involved with, in the sense that they called us in and they asked us if we were interested in this, is called Genoma.
Mm-hmm.
So are you aware of Genoma?
Yeah, I'm aware of Genoma and aware of other. And it's a good service. What they really do is any medication that you take has to be absorbed and metabolized by your system. The system in the liver that metabolizes those drugs is the cytochrome P450 system.
Mm-hmm.
And there are different enzymes in that system that render the medication either useful or not useful. Many individuals have different genes, so they may not have the capacity to metabolize that particular medication. So what Genoma will do is look into your genes and look as to what kind of enzymes you have or don't have, or have too much of it or too little of it. And it will give you an idea which medications are useful for you based on that profile.
Now, do you think that's useful? Because we're actually doing this with our family member since we've seemed to gotten into a point with them that all we're doing is trying medications, and then when the medication doesn't work, it's a while to get off of it, and it creates a huge crisis for that person. So I feel like we're playing this game with their brain. So we're actually going to do that for help. So it's not the answer is what you're saying, but it's helpful.
It's very helpful because it will let the psychiatrist know which medications are better handled by that patient. Some of these medications that people take have to be converted into something else in the liver. If you don't have the enzyme, which is the chemical, to convert that medication to the active ingredient, which is the real medication, then the medication will be ineffective. If, on the other hand, you don't have a way of handling that medication, then the medication can become toxic and have a lot of side effects.
Have you ever had an opportunity to have someone who's done this?
We have seen some patients in the inpatient unit, and we have tried different medications that were recommended, because each of the medications have a particular profile of through which enzyme system is the drug metabolized. There is 5 or 7 that we know at this point.
Mm-hmm.
So if you know that this patient doesn't have the enzymes or the chemicals to handle the medication, then you know that that medication is not good for that patient, and you move to the next one. The good things about those programs, it will tell you, based on your genetic makeup, what medications you can handle, which medications you cannot handle.
So what we're looking for, on a personal level is some assistance with that, having had this family member really go through a lot of angst and changes that have impacted, her family relationships, her work relationships, and to try to preserve that somehow. And insurance does play a role. What's interesting I found is that Anthem Blue Cross, which I'm hoping to get someone on from the insurance industry come on, we happen to have Anthem Blue Cross through the state. My husband's a retired employee, and find it to be an excellent coverage for almost everything. But it doesn't cover this particular test. Yet Medicare will cover it. Connecticut does cover it. So what I see, how I look at this is that not everyone's going to jump on this because it's going to impact the insurance companies, but it's going to impact gravely, I think, the pharmaceutical industry. Because the pharmaceutical industry, if in fact it comes back with recommendations, and the reports that I've seen from Genoma have been, there's a green zone, there's a yellow zone, and there's a red zone. So in the green zone, depending upon your system, there's recommendations of medications that they feel will work according to your pathways, is what this physician had said to me, or this scientist had said to me. But what you're saying is really enzymes. The yellow zone at the report that I looked at as a sample were medications that could work, but you might need a higher dose or a lower dose, and it goes back to your explanation as to why. And the red zone were medications that absolutely would not work on someone. So I do find that to be helpful. But when you look at the pharmaceutical industry, if it comes out that everything in the green zone are your really inexpensive medications, that's going to impact them. So I don't see, like me in 23, I think was one of the first tests that come out a number of years ago. I think we're heading more towards personalized medicine, that maybe my genetics and your genetics are different, so how I would manage drugs would be different, and it should really be really based on my genetics versus general public. It'd be interesting to see where that goes. A little bit off the subject, but similar, I can remember years ago having discussions with physicians about medication dosing based on weight. So I had a few years that I worked in the neonatal ICU, and they were little neonates, very tiny babies, and we did all of our medication calculations with the pharmacy based on weight. When I then left there and went back into the adult population and worked in the community, and obesity is a huge problem in our, a big problem in our society, I had many clients out in the community who were 300 and 400 pounds, yet the dosing for an antibiotic, for instance, was the same dosing that I would get being of average weight, maybe a little bit more than average weight, than the 300 or 400 pound person. So I think for me, that was one of the first aha moments, that we're really not looking at the person, and having a discussion with his physician at the time and saying, maybe this antibiotic isn't working for him because he weighs 400 pounds. Now, what they came back to me with, that in some cases it doesn't matter, but in some cases does it matter? And does weight play a role in what you do for dosing?
Yeah, weight and constitution. I think weight works to some extent for medication, but a lot has to do going back to the enzymes and the genetic profile of that person. Obviously, if you have a very tiny, frail person, you're not going to give the same dose of, for example, benzodiazepines if you're going to use them, or an antidepressant or an antipsychotic medication. So you have to be careful with that. So you have to dose lower based on what you see who this person is. I have seen people who are very thin, very small, that can tolerate medications like there was a never-ending pit. You can throw medications in and nothing happens.
So then it goes back to their genetic makeup and their ability to manage that. So where do you see psychiatry coming? Because I think that you're in that revolution again that you talked about in the years that you began. The whole reason we started the radio show is that I feel healthcare in general is in a revolution, which is change.
And I think, do you see more people being more educated about coming in? What are what are your thoughts about where are we going to go?
Well, I think the first thing is genetics. I think the fact that some patients don't respond to some medications is based on their genetic makeup. So personalized medicine is going to come into place. Finding the right medication for the right person. The only problem is that some of the newer medications are not covered by insurance companies.
Mm-hmm.
So it goes back to the same financial issues. New medications come into the market. They may be the right medication for you, but it happens to be a tier 2 or a tier 3 medication, which means that, we cover it, but we only pay 10% of it.
And they're usually pretty expensive.
Mm-hmm. So, and the issue is also about the pharmaceutical industry, how they make all their profits in the beginning of the introduction of the medication.
Before it becomes a generic.
And then it's no longer available.
Right, and although I've had some pretty hearty discussions with insurance companies for some of our clients on behalf of them, they often come back and say, we don't manage care. And my comment to them is you absolutely do manage care, because if there's a denial of something that obviously is needed, then you're denying that person. And I think what the insurance companies have done is taken away the expertise from physicians. And a small example of that is in talking to my primary physician, she was telling me one time, he said, if someone comes in with GERD, depending upon their insurance, she may feel that that person needs pill B, but she knows the insurance company will not pay for pill B until that person went on pill A. Person goes on pill A, even though clinically, as an expert physician, she feels pill A isn't going to work. But because of insurance, they go on pill A. They're miserable for another 2 to 3 weeks. It doesn't work. Now the insurance company's wasted money, really, on paying for pill A. That patient comes back, and now she's allowed to say, well, now we're going to try pill B. And it's not really allowed. That's the wrong term, because we are a society that feels that insurance should be paying for everything. But I understand that. But most people can't afford to spend $1,000 for a medication, regardless of where they're at. And should they be spending that, and is that the actual cost for it? So it does go back to insurance. And I think we all need to be working together on this, because if they're penny wise and pound foolish, as often the healthcare system is, related to a whole lot of things, then if as a team effort we're having discussions with hospital systems and insurance companies and the community about the needs, it seems to me at the end, it's kind of a win-win for everyone.
I think the legislatures need to make changes to force insurances to recognize that they're practicing medicine to some extent.
Correct.
I work in the inpatient setting, and sometimes we have this patient that I feel need to be in the hospital longer. And the insurance company, the reviewer, who could be, it's not a physician first.
Right.
It's probably a mental health worker,
or a
it could
nurse.
be a nurse, or it could be a social worker, will deny service. I say, I disagree with you. So they set up an interview with a physician, and you call a 188 number or a 1877 number, which happens to be a physician maybe in Alaska, maybe in Minnesota. And this person has no idea of what goes on into your state. For example, I have had cases that the patient initially was not taking medications, so we had to go through a legal process to force medications on the patient. So this physician I was talking to is from a state that you can start doing that almost right away. So he was telling me, why you didn't start medications right away? So, well, we have a process here in Connecticut. You have to go through a legal process to get medications against your will. Oh, well, that's not the way we do it here.
Very frustrating. And I actually have a client that I have conservatorship, a person of, who is in one of the locked psychiatric units in Connecticut in her 70s, who has bipolar and schizophrenia. She had been refusing medicine, so
after having multiple issues and hospitalizations, they were able to put it in her food and give it to her. When she went back to the facility, I got a call and said, we can't do that legally. So I actually had to petition the court to come up with an order for them to be able to give it to her in her food, which some of it were anti-seizure medications, and she's been absolutely fine. So you're right. You know, you've got someone out in East Oshkosh that's trying to direct care for you in Connecticut. So from a physician's perspective, it is difficult. And now that they're forcing you to release this person that you feel you're not comfortable with, first of all, the responsibility and onus of it is on you, because now you've made that decision against your will based on the insurance company. So how do you document that? And then what are your fears now that you've sent that person back out there?
At least the good thing about St. Francis is that we have latitude. I have kept patients in the hospital way beyond the time that the insurance have approved, and we have lost some money on those patients. Eventually, there's an appeal process that you can do, and sometimes you win, sometimes you lose. But as a physician, it's your responsibility. You really cannot discharge a patient that you don't feel is unsafe to do so. So at least in our culture at St. Francis, we have make it very clear that if we don't feel the patient is safe to be discharged, we're not going to discharge that patient. Other institutions may be a little different, but in our system, because we have a mission, you know, to provide care, to provide safety for the patients, we will not discharge a patient unless we're sure that that patient will be safe.
And I think that's wonderful. You know, years ago, I can remember having people, I used to volunteer at one of the shelters, and I can remember a particular hospital that wasn't St. Francis that actually discharged a homeless gentleman to the homeless shelter in a Johnny, in a taxi, no clothing, and I believe it was all over the newspapers back then, but that doesn't go on anymore. But it just tells us how our society from then to now, thank goodness, has changed. But it is all based on income, and you know, you have to function with some kind of revenue coming in to pay for people. I do think that St. Francis's mission does support a lot. I've had that even happen at St. Francis with many of my clients who've been inpatient on the medical side of it, and I do believe that they're really good about fighting for that. Tell me where your psychiatric unit is, Dr. Gonzalez.
Our psychiatric unit is north end of Hartford, which is an all Mount Sinai campus, which is Blue Hills Avenue and Tower Avenue in that corner. We have 3 inpatient units, 1 adolescent child, 1 dual diagnosis, detox unit, and a straight psych unit.
I didn't realize that you had that many units.
And then recently the hospital acquired Johnson Memorial Hospital.
Correct.
And there's also a 20-bed psychiatric unit there, and that's in the Somers, Stratford Spring area.
Correct. I'm familiar with them. So we're talking to Dr. Gonzalez, who is the chairman of the psychiatric department from St. Francis Hospital in Hartford, and this is Revolution Healthcare Radio. Your host is Sharon Gauthier. We will be going to a quick break, and when we come back, we're going to talk more to Dr. Gonzalez about psychiatric problems in our society.
For over a decade, Home Helpers has been making life easier for those in need.
I was very impressed when we first met. So why don't you tell me a little bit about the reasons why you actually got into this?
For me, it's personal. I took care of my aging parents who wanted to stay at home. We actually had a good experience having a home health aide come in and give us respite to make it as comfortable as possible, keep them in control, keep them at home, which was very, very important to my family. Home Helpers share that same vision. We picked Home Helpers because they're extremely strict about the quality of care, the training of the caregivers. They're very serious about putting someone in the home and making sure they're insured, bonded, and well qualified to take care of someone's loved one.
Are you looking for senior care for an aging parent or loved one? Are you a new mom or working parent who could use an extra hand? Let Home Helpers of Connecticut make your life easy. Get a free consultation. Call 860-698-2244 or find the nearest office at homehelpershomecare.com.
You now have a choice in flu vaccines. You can ask for Flublok. No actual flu virus is used to make Flublok. Flublok protects against the flu. No gluten, no latex, no eggs, no antibiotics, or no formaldehyde. Flu Block is proven to provide broad protection against multiple strains of the flu. The next time you get a flu shot, ask for Flu Block, the pure choice, because you have a choice in flu vaccines.
Welcome back, everybody. You're listening to Revolution Healthcare Radio. This is Sharon Gauthier, your host, and I have Dr. Gonzalez, who is the chairman of the Psychiatric Department at St. Francis Hospital. We have about 10 minutes left, and we've touched on a lot of topics. You'll have access to this show at St. Francis's website if you go under, what is it under? Under news or?
If you go to stfranciscare.com, on the homepage, you'll find news at the bottom.
Okay, if you go to stfranciscare.com, under news, you'll be able to find, we have another gentleman here.
Good morning.
From the media department. How are you?
Good, I'm great.
Yeah. So where can they access this show?
If you can go to stfranciscare.com, at the bottom of the homepage, you'll see a section for news releases, and you can access information there.
Excellent. So the show will be there forever, because I picked up your show back in April that you had done somewhere. And then also you can go to revolutionhealthcareradio.com. We'll also have that up there along with Dr. Gonzalez's wonderful picture. It's actually a really good picture of you that you'll be able to listen to the radio show. So we're going to deviate a little bit from what we were talking about, because one of my passions is the elderly, as I'm slowly approaching an elderly state myself. Our particular nursing practice does work with elderly patients mostly, or elderly clients. And Dina from your department, is it Martinelli? No, Dina?
Tampi.
Dina Martinelli must be somebody else. So Dina Tampi is the executive director, actually, of the psychiatric department, a registered nurse. And we've had multiple conversations along with Patty LaMonica in the ER. So here's one of my several pet peeves in life, is that if I have a client who's in a memory care unit, which there's a lot of education that needs to be out there about what's out there. It's not just convalescent homes anymore. It's private memory care units. It's private elderly communities that these residents are in, and they have a behavior issue normally related to probably a urinary tract infection, and they go to the ER. And for the ones that we manage, because we're a 24-hour service, we will be called and we'll show up in the ER. And what I always find is that elderly person in the locked unit with everyone else. So they're next to the alcoholic that might be in 2 or 4 point restraint. They're next to the drug overdose that now is awake and be medically clear, and they're in there. And now I have my little 85-year-old lady with dementia that I feel I can't leave because I have to protect her, right, from the system. And is there an alternative to that? And also, what kind of education are we providing the staff? Because what I have found that a lot of them, the moment they hear dementia, they don't talk to anyone. So many of my dementia clients you can have great conversations with. And they're actually pretty well directed if you tell them what to do. So we need to resolve that. I want to see a better way of managing. And when we took our last break, I was talking to you about Johnson Memorial. I understand does have separate area for the elderly. So what is your sense on that? And do you find more and more you're getting people with dementia that are being admitted, and you have your residents coming in who have no idea, no identification who these people are? And it's a problem.
Well, dementia is going to be a big public health problem. It is going to get worse and worse as time goes by. Our population is aging. Currently like 13% of the population is over 65 years old, and that's going to go up to 20%. Of those, 10 to 20% may develop dementia. And the question is, what are we going to do with them? The cost of caring for patients with dementia is going to keep escalating. And the question is, what do you do for them to avoid high expense care?
And hospitalization. We had Nora Dunn, who was on our show, who is with AARP. She's the director. And what she was saying in Connecticut, there's 500,000 caregivers, non-paid caregivers, which means family members, friends, neighbors, that are caring for this elderly population to the tune of over $5 billion. So you're right. Where are we going to go with that?
Yeah, they say that the cost of treating somebody for dementia, the indirect economic and direct cost is around $40,000 a year.
Wow.
That means actual care given to the patient, in terms of medication, hospitalization, nursing care, or hours of productivity that the caretaker cannot take. I think it's a matter of education. When somebody has dementia, doesn't mean they have to be institutionalized. It means that they need some care. As you mentioned before, something as simple as a UTI or urinary tract infection can make somebody more confused. Medications that are given by their primary care physicians sometimes escalate the problem, make patients more confused, more disoriented, more agitated. My idea, we're trying to develop a geriatric program at St. Francis. That's one of our main missions, to go along the ACOs, like animal care organizations, in which we will be addressing those patients that come in with cognitive disorders.
And how to manage them.
How to manage them. First of all, how to diagnose them. Not everybody that has memory and cognitive problem has dementia.
Correct.
There are people with delirium. There are people with have minor dementia. How to manage those cases.
Right. Well, I definitely want to have you come back with Dina, because she and I have had a lot of conversations, and maybe even Dr. Wolf or Patty LaMonica from the ER to continue this conversation, because for me, it hits us on a professional level to go in and see clients that may not be managed, and to see staff that are afraid of them. I think that's what pains me, is that they really don't know how to manage them. I thank you for coming on the show, Dr. Gonzalez. We'll have you back again. I thank our listeners. Even though you may be out getting a Christmas tree, you can get this show again from stfranciscare.com along with revolutionhealthcare.com. Thank you for listening. Next week will be a surprise as to who we have on our radio show. You're listening to Revolution Healthcare Radio, and your host is Sharon Gauthier. Thank you, and have a great week.
Revolution Healthcare Radio, brought to you by Home Helpers of Connecticut and Protein Sciences, the creators of FluBlock.
Let Home Helpers of Connecticut make your life easy. Get a free consultation. Call 860-698-2244 or find the nearest office at homehelpershomecare.com.
No actual flu virus is used to make FluBlock. The next time you get a flu shot, ask for FluBlock, the pure choice, because you have a choice in flu vaccines.
Thank you for listening to Revolution Healthcare Radio. Want to learn more about the show? Visit revolutionhealthcareradio.com. You can also access old shows, learn more about our guests, and contact us with your questions. Coming soon, the Revolution Healthcare Podcast. The people who never talk and the stories that don't exist. The podcast is a more intimate, in-depth examination of the personal challenges caused by healthcare. The focus is on the human aspect of healthcare, from patients and families to doctors and nurses. They all have a story that needs to be heard.